So I always tell patients that their pelvis is a lot like Manhattan. You have a really small space, a ton of real estate, and everything's interconnected. You know, one of the nice things about UW is that we have this multidisciplinary approach to care where I can get my urology colleagues in, I can get my colorectal surgery colleagues in, I can get you into PT, we can get you into sex therapy, and we can kind of approach from a multidisciplinary lens that really provides holistic care to these patients.
Hello and welcome to our Winnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a very exciting program planned for today. We're currently in our third season and thrilled to be back in the studio here at the Department of Urology at the University of Wisconsin. The purpose of these podcasts is to highlight some of the exciting and innovative work being done at the University of Wisconsin within our department, but we also like to bring in some outstanding guests from outside our department to provide their unique perspectives and highlight the collaborative efforts that are required to innovate. We also want to generate discussion within the broader community so we can continue to work together to make innovative advancements in urologic care. Now, with no further ado, I'm excited to introduce our guests for today, Dr. John Pennycuff and Dr. Frank Lin. Starting with Dr. Pennycuff, he's an assistant professor in the Department of Obstetrics and Gynecology at UW-Madison, where he's also the ERPS Fellowship Director. He did his medical school and residency at Emory University, followed by his fellowship at MedStar Georgetown University Hospital. And welcome to the program, John.
Thank you so much. I'm so glad to be here.
And Dr. Frank Lin is assistant professor of urology at the University of Wisconsin, where he joined faculty in 2020 after completing his fellowship with Dr. Nitti at UCLA. Prior to that, he was a urology resident at the University of Arizona. He did his undergrad at Penn, where he also received his master's degree in engineering biotechnology. Frank co-leads the department simulation program and is an assistant program director for the urology residency program and is also a frequent guest on our podcast. Welcome, Frank.
Thanks for having me.
It's really, truly amazing to have the two princes of prolapse in the studio to discuss the topic for today, which is pelvic organ prolapse. State of the art. Maybe I'll toss this one over to Frank. How did you get interested in caring for patients with prolapse? How did this become your life's passion?
Yeah, if you would have asked me this back when I was a medical student or even early in residency, I actually was more interested in oncology, much like yourself. And I dreamt of doing big open surgeries, 8, 12-hour surgeries. I thought would be a reasonable gig. However, later in residency, I found that I really enjoyed working with the older female patient. These patients were super grateful to have great care, surgical interventions that could help their prolapse, incontinence, and overactive bladder symptoms.
And what about you, John? How did you become interested in caring for women with prolapse?
Well, I think the nice thing about what we do is that we take care of patients and they get better, and you really change their life and you really provide a big change in their quality of life. And so I really like the fact that people are coming to you and they're saying, oh, I can't do the things that I like to do. I can't play golf anymore. I'm not playing tennis. I'm not visiting my grandkids because of what's going on. And we can offer some really great options for them that can be tailored to meet their needs. And then they get back to doing the things that they like to do. And that really appealed to sort of how I wanted to practice medicine and what I wanted my life to look like.
And that's kind of a good segue to the next question that I had. John, when you're seeing a patient in clinic, how do they typically present with prolapse? Or how do you evaluate them if they have a chief complaint of prolapse? I mean, I imagine they don't. As an oncologist, I don't see these patients typically in my office, but I imagine they don't walk in saying I have prolapse. So what are their, or maybe they do, but what are their symptoms and how do you work them up?
So oftentimes, they're coming to the gynecologist from my perspective because I'm gynecology trained, and they're like, oh my God, something's coming out of my vagina, and is this cancer? Is this life-threatening? Is this something I need to worry about? And so they're coming and they say, I felt something, I was gardening, I was active, I noticed a bulge, I felt something kind of come out, and I want to make sure that I want to know what's going on, and I want to make sure it's not something life-threatening. And that's when patients kind of come to see us. So they either notice some heaviness, they notice a bulge, they notice something kind of falling in their pelvic region. But when they're sort of referred to us, oftentimes the their primary care doctor or their internist might say, hey, you have a cystocele or a rectocele, or you got prolapse, you should go see, Dr. Lin or Dr. Pennycuff. And then those are the patients come and say like, oh, I totally have prolapse and I just want to get this checked out.
And then Frank, flipping it over to you, how do you evaluate the patient that walks in the door with one of these issues?
Yeah. So many of the patients have actually come in through the emergency room, actually, and I'm sure John's seen this as well, where they suddenly feel a bulge down below coming out of the vaginal area. They get worried that it's something dangerous or scary. They run to the emergency room. The emergency room doctor evaluates it, says, you know what, it's not something dangerous or scary, just see urogynecology. The evaluation really is a really good history. How long has this been going on? How much does it bother you? And then a thorough pelvic examination, looking at the different compartments of the vaginal canal, looking at, if it's anterior apical or posterior compartment prolapse, and documenting that to track it.
And is pain a typical component of prolapse?
No, not typically. Not pain in the sense that, that they have acute onset discomfort or pain, but more like a pressure or a lower back discomfort. They might have some tissue irritation if the prolapse is significant or if the vaginal tissue is atrophied.
Now, I'm going to flip over to John for this next question. I was sort of thinking about a lot of what we do in medicine. We've had some neat advancements in technology that have helped us to work up our patients and evaluate them, help to make better diagnoses and diagnostic plans. And back when I was a resident, I remember working with a guy named Gopal Bedlani, who was ERP's urologist at Wake Forest, and he was showing me some very interesting I guess they were called functional MRIs, where you could actually see the prolapse actually in real time. And I don't know if that's taken off, or have there been any advancements? And I've been out of residency for 10 plus years now, but are there any advancements in imaging for patients that have prolapse, or any other tools that have come out more recently or coming down the pike to help in the evaluation of these patients?
Yeah. So, generally speaking, most of the time we can get our diagnosis just by seeing the patients in the office doing the physical exam. But sometimes it's, the symptoms aren't always clear, and sometimes having a little bit more information is helpful. And, that's a time where we might look at something like a dynamic MRI. And actually, Frank, Dr. Lin was one of the individuals at UW who spearheaded getting that technology here at UW. So it is available to our patients in the region. So, I think we use it as an adjunct. I think we use it when it's not clear what's going on, or if we think that we might benefit from getting some imaging. But, in general, we can get almost everything we need just by seeing the patients in the office, which is really nice for our patients.
Frank, how did you build the dynamic MRI or functional MRI program? And in your mind, which patients are best served by that sort of an evaluation?
Yeah, the dynamic MRI program for prolapse evaluation was in conjunction with the radiology department and their MRI specialists. It was actually something that I had learned about during residency and then subsequently fellowship at UCLA. And we got it started here at Wisconsin so that we could have it in our toolbox. And essentially, it's a 3-phase MRI study. There's a resting phase where the patient's laying in the scanner just at resting phase. There's a secondary phase, the Valsalva phase, where they bear down and try to push some of that prolapse out. And then finally, the third phase, which is critical, is the defecography phase, where they actually try to have a bowel movement and push out gel from the pelvic floor. So either rectal gel or vaginal gel out. And we can actually visualize that on the MRI. And that's picked up very nicely due to the contrast elements of the MRI scanner. It's not, as you can imagine, a fun test or a test that's not messy. However, it does give us a multi-compartment view, both the front, top, and the back. Can also serve to give us some functional evaluation, especially for those patients with some defecatory dysfunction. I like it for my patients specifically when they have physical exam findings that don't match their symptomology. If their symptomology is very bothersome, for example, or if they have some sort of prolapse failure and maybe you're trying to get a little bit more information regarding their pelvic floor movement, that might be symptomatic.
That's fascinating. Now, I want to go to John with the next topic, and it's sort of multidisciplinary management of patients with prolapse. How important is it? And when we say multidisciplinary management, what services are involved, and how critical is it to taking care of these patients?
So I always tell patients that their pelvis is a lot like Manhattan. You have a really small space, a ton of real estate, and everything's interconnected. So your bowels, your bladder, your pelvic organs, the musculature, the bony pelvis, it's all sort of interconnected. And so I think it's really important that we take a multimodal approach, that we have colleagues who are urology trained, we have our colorectal surgery colleagues, we have our PTs, and we have our sex therapists who, play obviously a big role. And so it's really nice to be able to look at a patient from a holistic standpoint and say, one of the nice things about UW is that we have this multidisciplinary approach to care where I can get my urology colleagues in, I can get my colorectal surgery colleagues in, I can get you into PT, we can get you into sex therapy, and we can kind of approach from a multidisciplinary lens that really provides holistic care to these patients.
And you and Frank get along? Is that true or?
Absolutely.
Oh,
absolutely. We get along every single day. No. I'm so grateful to have him because I'm GYN trained, and so while I have some urology training as part of my fellowship, I don't have nearly as much as obviously as a urologist. And so there will be times when I come in and I'm like, this is really. I need some input from a urology colleague, and it's nice to be able to just go down the hall to Frank's office and say, hey, this is what I'm thinking. What would you do? Should I be looking at it differently? How can we help this patient? And Frank is always super helpful.
We actually operate together quite a bit. That's the other piece that people don't see us doing very often is there's collaboration in the operating room as well.
And I do think that is one of the benefits of UW, right? Like we have an infrastructure that allows us to be super collaborative. So when we need to bring someone in, we're able to do that. And ultimately patients get the best care because of it.
And I think from a wellness standpoint, from a surgeon and wellness, I think working closely with colleagues, to me, is one of the most fulfilling things that we do. Obviously, taking care of patients is highly fulfilling as well, but having great partners, and I collaborate a lot with colorectal surgery and plastic surgery, and those types of relationships really are what keeps me full of joy. So I'm glad to hear you guys get along so great as well. I want to shift gears a little bit. I thought about starting the program with the mesh controversy, but I thought we would kind of leave it for the middle so that people would hopefully not just tune out after we got through the controversial part of the podcast. I know a little bit about the mesh controversy because when I was in training, my residency, we were putting in a lot of mesh in patients that had pelvic organ prolapse. I finished my residency in 2012, but I believe subsequently there's been some issues with mesh in the vagina from an erosion and extrusion standpoint. So maybe Frank, can you expound upon the current state with the mesh and how we kind of got there in the first place?
Yeah, we can talk about the FDA ban of transvaginal prolapse mesh kits of 2019, and John can sort of talk about things that subsequently happened. There was a series of warnings about transvaginal mesh kits that were available commercially. These were different types of meshes that were being placed through the vagina for specifically vaginal prolapse, that diagnosis. And ultimately, they were taken off the market by the FDA in 2019. And they're no longer allowed. We're not allowed to use those kits. They're not commercially available. And certainly not everyone had complications related to these kits. However, there were enough flags that were raised that they felt better to pull them off the market.
And so the mesh was I guess, John, how is the mesh causing problems, or was it the mesh itself, or was it the operation? Help us to sort of understand maybe some of the finer points.
Yeah. So I think there's a lot of nuance, to using mesh. And the first thing I tell patients is we've been using mesh for a really, really long time. If you had a hernia repair, if you needed abdominal reconstruction, those general surgeons have been using mesh a long time. And meshes in general have come a long way, but the meshes that we use, it's essentially the same material, but it's about where we put the material and about who's doing it. And the truth of the matter is, when we were fixing prolapse from a bottom-up approach, and what I mean by that, when we were going through the vagina to fix prolapse vaginally up, that just putting that mesh in that plane of tissue wasn't the best application of mesh. And so even though the meshes we use today that Dr. Lin and I use from a top-down approach is the same material, you have just less complications. You have less constriction, you have less stricture, you have less scarring, you have less mesh erosion into the vagina. And while it can still happen, it's much rarer. And in fact, our application of the mesh today, it was never included in the black box warning. So the black box warning that the FDA had didn't include the use of mesh for sacrocolpopexy or incontinence. And I kind of tell patients that to try and bring it to something we can all understand, because it sounds very scientific, and it sounds very like you're kind of getting lost in all the details. I always say, imagine your living room and you're using drywall. It's a great material to build walls. But if you take that same drywall and you put it in a bathroom that's hot and there's a lot of moisture, you're going to have problems because it's a great material, but in the wrong place. And so the mesh we use today is a great material for the right patients, and we're using it in the right place. And the other thing I say is there's a difference between me putting drywall up. I don't know anything. I don't know what I'm doing about putting drywall up. Of course, we're going to have problems. We're going to have all sorts of complications if I try and do my own drywall. But you take a master carpenter, someone that actually knows what they're doing, someone that's actually spent time learning about this and working on it, they're going to do a great job because they have the knowledge. Well, there were doctors that really didn't devote their life and their career to fellowship and doing this who are having problems. Whereas, doctors like Dr. Lin and I, we have devoted our career to making, to understanding mesh and using it appropriately in the appropriate patients.
I tell you what, Dr. Pennycuff has some really nice analogies. I really love those.
I'm liking these. These are great.
That's good stuff. I was thinking about getting some carpentry done at my house, so don't go to John for that.
Well, don't come asking me. You will not end well.
I'll go to Angie's list. That'll be good. Good stuff. Now, so what I'm hearing both Frank and John say is that mesh put in transvaginally is not a good option for surgical repair of prolapse in 2025. So the next logical question then, Frank, is so what is, and how do you decide what operation to do in 2025 to help these women that have symptomatic prolapse? And then I guess the secondary question is if somebody has prolapse and they're not symptomatic, how do you decide who to operate on and who not to?
Yeah, so there are still two categories of meshes that are FDA approved, on the market, safe for use. And one of them is mid-urethral slings. That word sling is used in so many different ways by patients, and it's misunderstood, but really that's for stress urinary incontinence. And that's a separate topic that we won't get into today, but that's a huge category of products out there that we do use for our patients for leakage with activity. The other category is, of course, the abdominally placed meshes that we're typically doing robotically or laparoscopically. And these are for, as John mentioned, the top-down approach or transabdominal approach meshes that are still on the market, considered safe and very efficacious.
Hey, John, if you have a woman that comes in and they're just concerned about a bulge, but they're not really that bothered by it, how do you decide which patients would benefit from an operation?
So I always talk to patients and I sort of say, if this isn't bothering you, if it's not affecting your day-to-day, if you're not avoiding activities, we don't need to do anything about it, right? I explain to them that this isn't cancer. It's not life-threatening. We talk about how it might worsen with time. It could affect their ability to urinate. right? Like they may notice some bleeding, especially if the tissue gets, kind of raw or kind of excoriated, as we say. But ultimately, if a patient's not bothered, we don't have to do anything. And so when we're making when we're having a conversation about when to pursue surgery and when not to, I always talk about that no surgery is without risks. And so while the risks of these procedures is pretty low, it's not zero. And so the patient has to feel comfortable with, what the next step for me is worth taking this risk, that the benefits outweigh the risk that I'm going to potentially take on with having a surgery. And if a patient's not there, if they're like, I'm too worried about the risks, I'm not bothered enough, and the risks sort of outweigh their bother, then it's not the right time. And it's really, I think one of the nice things in urogynecology and pelvic reconstructive surgeries, we really get to talk with our patients, understand their goals of care, understand their values, understand what matters most to them, and help them tailor a treatment plan, whether it's observation and no active treatment, conservative management, maybe with pelvic floor PT or pessary, or surgical management that's more invasive. We really tailor that treatment plan to what the patient is looking for.
I think that's really a great way of describing it, John, and I think a breath of fresh air. You have these wonderful discussions with patients, and not all patients with prolapse need surgery or will benefit from surgery, and there are other options, which is a good segue to the next question that I had, and I'll punt this one over to Frank, perhaps. Anything new in the world? I heard John say the P word, the pessary word. Maybe you can describe a little bit about sort of non-surgical approaches to symptomatic prolapse, as well as anything new or innovative that is out there that doesn't require a surgical incision.
Yeah, conservative management includes physical therapy with a pelvic floor physical therapist. These are great additions to our multidisciplinary clinic and can really optimize patient symptomology without ever hitting the operating room. Pessaries are another option. These are typically silicone rubber devices that are fitted into the vaginal canal. I tell my patients, they're like, if the roof of the building caved in, we'd go back in there and prop it up with 2x4s. It's functional, but it's not fixed. And that's sort of how I view a pessary.
Another carpentry analogy, so that's good.
Yeah, that's right. Another analogy for this podcast, which is great. There are a number of lasers and energies that have been on the market. None of them have ever been shown to effectively treat prolapse over the long term to a degree that surgery can.
John, would you say the gold standard or maybe the preferred surgical approach then it would be a robotic for patients with prolapse?
I think that we often talk about how sacrocolpopexy is the gold standard for treating pelvic organ prolapse. And, I do robotics, I do laparoscopic. The data is pretty clear that both are good for patients. One isn't necessarily favorable over the other, but some surgeons prefer to use the robot, and that's perfectly fine. And some surgeons prefer to do a laparoscopic approach. I challenge a little bit the notion that a sacrocolpopexy is the gold standard, because again, the best surgery for the patient is the right one for the patient. And whether that's a vaginal approach or, a laparoscopic or robotic approach using mesh, that's really about shared decision-making and informed consent. And so, again, I know many people will say that, but I really think you've got to listen to the patient in front of you, understand what the patient's goals and what they care about and what their, how risk averse they are, and then tailor that plan. But the nice thing is, whether it's a vaginal approach or whether it's a laparoscopic approach, straight stick, robotic, or otherwise, we have the skill set here to sort of give the patient the best outcomes possible.
I agree with John specifically that there's no gold standard surgery. There are surgeries and they have different risks and benefits. A lot of the argument about sacrocolpopexy is that it does use a mesh augment for the repair. And some patients just don't want that. Additionally, it's a transabdominal approach. And so some patients may not be candidates for transabdominal surgery. Either they have a number of abdominal surgical history is significant, or something else that precludes their ability to have a laparoscopic or robotic approach. And so a transvaginal approach is very reasonable at that point.
And when you're doing a transvaginal approach, Frank, are you still putting mesh in, or how are you managing that? And does it depend on the compartment that's involved? Is it, anterior, posterior, rectocele? Do you have to tailor it based on the anatomy?
That's exactly right. It has to be tailored to the compartment that's failing and has prolapse. And these are considered native tissue repairs done without mesh augmentation.
Are you using any sort of autologous tissue to augment the repair transvaginally?
Yeah, there are some small series with medium-term outcomes that are looking at different non-mesh augmentation materials. So one of them would be autologous fascia, either rectus fascia from the abdominal wall or fascia lata off the lateral thigh. And these have been described for reinforcement transvaginally as well as transabdominally in lieu of sacrocolpopexy mesh.
Anything to add to that, Dr. Pennycuff, from a transvaginal approach viewpoint?
Yeah, I mean, there are some instances where we might want to use an allograft. There are some commercially available allografts that we use. That's typically cadaveric tissue, is what we mean when we say allograft, and so there are some instances where it might make sense, perhaps if you're doing, someone failed their first repair and you're trying to reinforce the tissue and you're going from a vaginal approach. But in general, I don't find myself using a lot of allografts in my practice. I think that we have great outcomes using the patient's own tissue and suture when we're looking at from a transvaginal approach.
All right, we're nearing the end here. I wanted to finish by asking each of you to give me your pie in the sky view or dream of if you had unlimited resources that you could invest in solving the pelvic organ prolapse conundrum that patients experience, where would you put the money? I'll go to Frank first, and we'll give John the last word.
Prolapse, I think, starts during the time of vaginal delivery, and that's many times the initial event that causes the sequence of prolapse to occur much later in life. If there's research that should be done on like tissue engineering or things that can be done to maybe prevent prolapse from happening, would be a great fantasy of mine and research that would probably take us to the next 50 years.
Cesareans for everyone? Is that what you're saying, Frank?
Oh boy, not at all. But
you're going to get him in trouble. Absolutely not.
Absolutely not.
What about you, John?
I would love to see. I think advances in stem cell therapy and regenerative medicine are going to be really impactful. We're starting to do some research about injections that can be used in conjunction with mesh to help reduce mesh exposure in patients that have had mesh. But if we could inject a substance into the patient's own tissue, regrow the support structures that were in place prior to getting pregnant, prior to delivering, prior to aging, that can combat some of the genetic components associated with prolapse, that would be great. And these would be injections that would be done that would help, eliminate the need for more invasive surgical repair down the road. That's what I would love to see happen.
Very interesting. It's been great having both Dr. Frank Lin and Dr. John Pennycuff on the program tonight. Thank you both for being such great guests and for having a great discussion on pelvic organ prolapse state of the art.
Great to be here. Thank you so much.
Thanks for having us.
The Prolapse Princes or Princes of Prolapse have spoken, and we've enjoyed having this great discussion. I want to thank my editor and producer, Sandra Miller, as well as Dr. Steve Nakata, the chair of the Department of Urology. This is Winnovations. I'm your host, Kyle Richards, and thanks again for tuning in.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.